year, there are 300,000 maternal deaths, 2.4 million neonatal deaths, 5 million deaths in children under 5, and 2.6 million stillbirths. And a major share of these deaths occur in low and middle income countries, often in emergency care contexts where delays and resource constraints limit access to timely and appropriate care. And in these environments, frontline emergency providers are routinely exposed to high stress events like patient deterioration, preventable deaths from resource constraints or delays in care, moral distress, and intense workload pressure. Our previous work with the MCH Heat Team's focus group suggests clinicians rarely have structured support or debriefing processes, but many want these opportunities and these tools. So while our previous MCH Heat focus groups in the Kilimanjaro region identified gaps healthcare workers experience in staffing, training, and resources, many human-centered gaps and themes also emerged, surrounding blame, short-term and long-term mental health consequences, and a need for debriefing. The lived experience shared in these focus groups is concerning for provider well-being. Healthcare workers describe replaying events for days or weeks, worrying about long-term mental health impacts, and describing how blame can discourage learning. And this is the space where Tunaendelea is trying to intervene to promote reflection, recovery, and learning in a way that fits the Tanzanian context. So in this proposal, debriefing is defined as a discussion where healthcare workers talk through unanticipated or difficult patient events in a group setting to process emotions and stress, reflect, and to identify areas for care improvement. And we know from broader literature that formal peer support and debriefing can matter for reducing burnout, compassion fatigue, attrition, and psychological trauma risk in healthcare workers. But most formal frameworks and most of the evidence base originates in high-income settings, especially in North America and Europe. So this project builds off this gap through using existing debriefing and peer support framework approaches like Stop 5, the pause, stress first aid as a starting point for adaptation, then intentionally co-designing something culturally and practically grounded. So our core research question is, in the Kilimanjaro region, what priorities and components do emergency maternal, neonatal, and pediatric healthcare workers identify as necessary for a culturally grounded, relevant, and feasible debriefing and peer support framework? The primary objective of this project is to co-design the Tunaendelea debriefing and peer support framework with cultural congruence, local relevance, and long-term feasibility. And this leads us to our two specific aims. Aim 1, to understand which components are prioritized by these emergency neonatal, maternal, and pediatric healthcare workers and why. And Aim 2, co-design a culturally grounded and trauma-informed peer support and debriefing tools. And these objectives will guide us in our long-term goal of bolstering emergency and provider coping and resilience across settings in the region, with the goal of wider implementation of the Tunaendelea intervention. So this study utilizes a human-centered design approach, which breaks our work into 5 phases. So this is a longer-term project, and phases 1 through 3 will inform my thesis. And a qualitative data collected during our co-design workshop will be used to identify provider priorities and to create a preliminary framework. However, I want to briefly outline our full timeline while noting the scope of this project may change depending on funding we're waiting to hear back from. So therefore, keep in mind this is a preliminary outline. So phase 1 is exploration, and it was accomplished through our previous MCH Heat focus groups and identified the gap and need for debriefing. Phase 2 is ideation, and this phase will be conducted in June at our intervention co-design workshop, which I'll discuss further in the coming slides. Phase 3 is to create and prototype, which will be done using the list of priority components our intervention workshop identifies, and a preliminary model of the Tunaendelea framework will be created by our team and assessed and refined. Phase 4 is evaluation, which would involve a pilot at 4 facilities and assessment. And phase 5 would launch the framework in hospitals in the Kilimanjaro region. So our co-design workshop discussed in phase 2 will occur at Kilimanjaro Christian Medical Center, KCMC in Moshi, Tanzania, and it will be a day-long workshop. Participants will be emergency maternal, neonatal, and pediatric healthcare workers from KCMC, Pasua High, and Mwenzi hospitals, where our team already has previous partnerships. And these individuals will be recruited via convenience sampling. So for our inclusion criteria, they must work in the Kilimanjaro region as a nurse, doctor, or midwife, work at the current facility for at least 1 year, have at least 2 years of experience managing maternal, pediatric, or neonatal emergencies, and speak Kiswahili. For exclusion criteria, it would be if someone is not proficient enough in Kiswahili to participate or declining informed consent or participation. There we go. So next I'll walk us through a tentative schedule of our workshop, as the process is really important to make sure Tunaendelea is grounded in what clinicians experience and what they express a need for. And I want to note this may be expanded into a multi-day workshop depending on the funding we receive. However, we're currently planning for a 1-day workshop. Tanzanian-based team members, myself and Dr. Rent will be present and take detailed field notes throughout the workshop. So we'll start by presenting key findings from the MCH heat focus groups, especially regarding the gaps that came up around staffing, training, limited resources, and the lack of structured peer support and debriefing, alongside the theme that healthcare workers can sometimes experience blame after difficult cases. From there, we'll move into an open discussion, and the goal here is validation and expansion. We'll ask questions like, does this reflect your experience? What information do you think is missing from the focus groups or could be described further? And specifically, what feels missing in terms of healthcare worker support and debriefing in your work setting. After that, we'll emphasize the human-centered gaps we're focusing on today in the workshop, which are debriefing and peer support specifically, as less is currently known about how to resolve these. Then we'll briefly introduce a few existing frameworks as starting points. And this includes STOP 5, which is a quick 5-minute debrief, the Pause for Challenging Clinical Encounters, and Stress First Aid, which is a stepwise trauma-informed approach with early peer check-ins. Next, we'll split into 2 small groups, one focused on debriefing and the other will focus on peer support. And each group will individually discuss which elements of these frameworks would be helpful, which would be realistic given the work environment, time, resources, and cultural context, and which would not. And this is where we'll start generating the actual components that are culturally and operationally feasible. Then we'll reconvene for a large group synthesis where we compare what emerged from both groups, reconcile differences, and refine a list of clear candidate components for Tunaendelea. And finally, we'll close with wrap-up remarks, reiterating identified priorities, and next steps for our research team to develop a preliminary prototype. Again, the construct we're trying to capture is what priorities and components clinicians deem essential for feasible, culturally grounded, and peer-supported debriefing. So in addition to our co-developed list of key components, we'll further investigate priorities through qualitative analysis of detailed field notes taken during the workshop. And this includes notes from our open discussions, small group discussions, and large group discussions. Our analysis method is a conventional content analysis technique, combining a priori coding and inductive coding. Furthermore, all documents will be double-coded, once by a Tanzanian-based team member and once by a US-based team member, using the deduce platform, and disagreements will be resolved through group consensus. So our anticipated output is a list of healthcare worker identified priorities and key components for the Tunaendelea peer support and debriefing framework. The use of field note analysis will allow us to find themes across priorities and translate our framework into a coherent and context-appropriate, easy-to-use final product. The next steps after we conduct our co-design workshop and develop a preliminary framework is to pilot and revise with potential end users. And this will be done through quantitative analysis. However, the timing again will depend on the funding opportunities, and the measurements we will use are the accessibility of intervention measure to understand how much users welcome or like our framework, appropriateness of intervention measure to understand how well users think the framework fits the context, problem, and workflow of hospitals, and finally, the feasibility of implementation measure to understand if users think the framework can be implemented based on context, ease, resources, and practicality. So ethics-wise, this study involves minimal risk to participants. The main risk is emotional distress through discussing and listening to stories of difficult patient events and losses. For mitigation strategies, participants can skip questions, pause, or withdraw from the workshop at any time, and we'll use anonymous identifiers and confidentiality protections within field notes. Ethical approvals will be through Duke, KCMC, and NIMRI. So thank you so much for your attention. I want to open up the space for audience questions, and also I have a few questions I'd like the team's feedback on. Thank you.
Thank you, Lauren. Does anyone have questions or comments for Lauren? Go ahead, Catherine.
Lauren, great job, great presentation. I love the project. I'd like to help with additional feedback for the AIM, AAM, and FIM mechanisms.
Yeah.
We had a lot of conversation last week at the implementation science course that we teach in Tanzania. And we also talk about this a lot at our global health course. These three quantitative tools are Likert scale tools. They're not exactly quantitative, but they're not exactly qualitative. And in some ways, I call them useless. And in some ways, I call them a good thermometer. It just depends on how you use them. So you have to use them very cautiously. Because they are essentially a Likert scale, you're going to get a score of 1, 2, 3, 4, or 5 on 5 different questions. And when you're done with that score, you're going to end up with a number that doesn't mean anything to you. It's not going to help you very much at all. And so you're going to have to think through what is it that you're getting from this scale and the score? Why is it helping you? One of the ways that we use it that I do suggest it be used, many ways I just say don't bother, it's not worth it. Sometimes you need to write something into a grant and that's what you do it for. But some ways that I suggest that it is used is a thermometer, that if not everybody agrees at level 5 of all the questions for each of these three tools, then you do a qualitative component, which is saying, okay, why don't you think this was appropriate? Why don't you think this was feasible? Why don't you think this was adoptable for your setting, whatever the question ends up being? What that does is it demonstrates that you get 100% of this population determines that it is the construct that you are asking for. And if it's not, it sets up for who you should ask further questions for. And what you should focus those questions around to be able to get exactly what you need for the methodology that you're looking at. So I think that might be the strongest way to use these tools in a mixed method fashion, following or ahead of some qualitative work. And part of the reason because of that is because they're very nondescript and they end up with like a scale that doesn't give you more information. So I hope that's helpful for you. Now, in terms of when to do this, I think you can do this through a couple of different time periods. I would say during an adaptation time period, you can get some information that is really good. As of, is it ready to go? Are we complete or do we need more? I would say during a piloting time period, it's great because you're processing that feasibility aspect and understanding what that's going to look like. But doing both is even better. So it's just going to depend on the time that you have.
Thank you so much. That's really, really helpful feedback. I appreciate that.
And Catherine, what about day up? I think, Lauren was like kindly alluding to this, but we're hoping to get more funding to kind of do more than a single day intervention workshop. But with the reality of like global health funding, we for her thesis, we might end up with that as like at least the only point or like data collection moment. What have you done and open to others from the group to kind of like with the same group that's doing co-design, at least preliminarily assess how close to the mark you are, I think is maybe what she's trying to get at in some of these questions too.
Yeah, so it depends on what kind of co-design methods you're doing. Co-design is really focused on participatory processes, and so the method of co-design will give you what kind of data collection you have. So if it's a nominal group technique, you have the ranking and voting, and if it's a Delphi, you have the whole process of the Delphi components. Or if you have modified, it's whatever you determine it is, right? So you can pull in components that are there. I think the day of is great data because what you want to see is that you want to see it be responsive. And in the beginning, everyone rip it apart. And then by the end, you're closer and closer to the tool saturation that you want to see, that 100% of a group, awesome, nominal group technique, perfect. Because when you do that, then you end up having some ranking in there. And with that ranking and voting, you end up bringing out more of an indication of what components are really important. But I would include them in the process of adaptation because in that process, you can start to understand when things are looking the way they should or whether there's more work to be done. And it's also going to depend upon how your team is feeling confident and empowered to speak, because if they don't feel like they can talk about it, they might be able to put something more opaque in these scales, right? They might not say, I know what to change, but they might say, I just don't think it's there yet. And that just gives you the sense that you might need to bring in more different people or pilot it more or work with it more. So I love these tools to be able to just get a gist, but they don't always give you final numbers that make you say, okay, I'm done and walk away. But they can give you sort of just that thermometer of how you're doing. Great question, Charla.
Any more comments, questions? Okay, thanks, Laurie, for your presentation. It's a great work.